Now we shall move on to infection prophylaxis for patients with GvHD. And maybe if you agree, but obviously, please feel free to jump in whenever you feel necessary to all colleagues attending about infection prophylaxis for patients with GvHD and why we thought that this infection topic is important, because actually, as we all know, we say, well, GvHD is a problem. But actually, when we look carefully, patients are not dying in general when it comes to severe acute GvHD, for instance, or severe chronic GvHD. They're not dying because of the skin severity or because of the gut localization severity, because actually we keep on adding immunosuppressive therapy and they become more and more immunocompromised. And obviously they will develop opportunistic infections. So the infectious, I would say, problem is always around, although we're focused on the management of GvHD. And this is why I think, and there is no clear guidance or universal, I would say, approach to infection prophylaxis when it comes to GvHD. So maybe we can start with acute GvHD, and usually this is in the early time after transplant. So we would have another issue to tackle, which is usually cytopenia or a poor bone marrow function. So when it comes to bacterial prophylaxis, antibacterial prophylaxis, what are the thoughts of the steering committee members, and what is the practice in your own center, and are things different from one place to another and maybe across the Atlantic? I don't know who wants to start there. And then we'll move on to viral and how to do it, and the fungal, and then we'll move on to chronic GvHD. So I need to ask for a designated volunteer there. Zina.
So maybe I can start.
Yeah, yes, Rob, please.
We do not give, in general, broad spectrum antibiotic prophylaxis in our patients with GvHD, but we react fast if there is a clinical sign like fever, loss of blood pressure, or coagulation problems, anything that indicates that there is bacteremia. We react fast with the broad spectrum antibiotics, but we do not give a prophylaxis. We give prophylaxis against pneumocystis carinii, and of course in the antiviral, which will come later today, but no standard antibacterial prophylaxis based on the unfavorable effects of broad spectrum antibiotics on microbial diversity. Therefore, we have stopped that, I think, more than 10 years ago. I know that there are some centers in Germany that still do it, but in general, I think most centers have stopped giving broad spectrum antibacterial prophylaxis.
Excellent, thank you. And you're highlighting an important issue, which is becoming more and more important. This is the issue of dysbiosis and the implication of systemic antibiotics. How is it in your center, Zina?
Thank you, Mohamad, everybody, and Robert as well. When you say broad spectrum antibiotics, Robert, do you think of, you're not thinking about preventive antibiotics like fluoroquinolones, you're just talking about the treatment of febrile neutropenia. I'm sure that was it, right?
So when I talk about broad spectrum, I mean meropenem,
okay, yeah,
and tazobactam, for example. Yeah. But we also don't give quinolones anymore. We do not give any antibiotics in the prophylaxis anymore.
Okay, I mean that's really important, the thing you highlighted, because several years ago I have also done analysis in my center, and we have shown that the choice of the antibiotics for febrile neutropenia, so in the first 30 days while they're hospitalized, actually changes the incidence of acute GvHD related mortality and acute GvHD, because of course we believe it's because it changes dysbiosis, and there are lots of data as well, well not lots of, but it's sufficient data showing that choice of, for example, cefepime over piperacillin, tazobactam, or meropenem, so the antibiotic that saves anaerobes, the good anaerobes, can change the incidence of acute GvHD-related mortality. And since those data have emerged, we have changed the practice. So usually earlier when we would give cefepime, we would add on metronidazole, because that's one that doesn't cover the anaerobes. And after knowing this new data, definitely we would prefer choosing cefepime, for example, over those other antibiotics, and we would not now add on metronidazole. So that's my comment further to Robert's.
But would you consider, for instance, because I know many centers would use just simple, in the absence of any infectious context, amoxicillin prophylaxis. Is this something common practice?
Yeah, we do that until the patient does get vaccination. So we do the after they get out from aplasia and they engraft, we continue with penicillin to prevent pneumococcus, and that's until they get vaccinated. And of course, the pneumocystis prophylaxis until the CD4s are less than 200. But I think Mohamad is talking to someone else, so somebody takes over. No, wait for him.
Yeah, no. Sorry, there are some technical issues. I have to change place because I'm not in my office.
I said that tradition, standardly we do penicillin until they get the vaccination for streptococcus pneumonia, and of course also the what's the name, the pneumocystis prophylaxis until the CD4s are less than 200. So that's
how is it in the US, Ibn? Because I think the use of quinolones is more frequent than in Europe. Am I correct?
I can only speak for us. I mean, it's a topic that I think the question needs to be carefully worded, because as you're seeing, there are centers that have empiric bacterial prophylaxis for certain events or certain timelines like this, or certain metrics that, again, it's not, in my mind, it's not really data driven by anything. And extrapolating from one transplant platform to another when the immune reconstitutions are completely different is tough for me to believe in a one-size-fits-all metric that has been used for decades. So we currently, for the question of pure patients who develop acute GvHD, we here do not use any antibacterial prophylaxis, sort of what Robert was saying, and they are not on any pre-existing antibacterial prophylaxis. I mean, they are on PJP and zoster prophylaxis. The only change we make is for patients with an acute gut who are in the hospital and get the high-dose corticosteroids and have the gut issue, their fungal prophylaxis changes and gets broadened. But everyone else, those who get oral steroids as an outpatient or anything else, they remain on their baseline, and for us, it's just fluconazole and then PJP and zoster. Again, the only change we make is we change fluconazole to something like IV mycofungin when they come in, just because of absorption issues and at least the loose data. That's the loose randomized data that's there that may or may not be able to be extrapolated. I mean, we used to give gram-negative prophylaxis in the form of a quinolone, and understanding that's not the broad spectrum stuff, but because we somewhat believe in the microbiome thing, though the cause and effect of that remains to be proven again, we try and spare and try and create said diversity or encourage and cultivate such.
Florent, can you, because several colleagues mentioned this issue of the impact of antibiotics on the microbiota and dysbiosis, can you just give us a brief overview about the current status and what we know about the negative impact of dysbiosis in the setting of acute GvHD, and of course, how to reconcile sometimes the need for antibiotics versus protecting the microbiome?
Yeah, so thank you, Mohamad, for this question. So far, what is clearly established is that there is a link between dysbiosis and patients' outcome when they have acute graft-versus-host disease, and in particular, patients with dysbiosis have a higher mortality related to graft-versus-host disease, and in particular, GI acute graft-versus-host disease. What we know is that there is some bacteria that are more protective. This is in particular bacteria that produce butyrate, such as Brosia, while there is some bacteria that are more detrimental, in particular the Enterococcus, that is truly detrimental. Nevertheless, when we are some patient with some fever that need to receive antibiotics, we need to treat the infection that can be very severe. And what we need to do is that we need to give the broad spectrum antibiotics to the patients. Of course, maybe it will be detrimental later for the graft-versus-host disease, increase the risk of mortality, but the aim so far is not to have the patient that will die right away because of the infections. What we should, the next step will be probably how we can restore or preserve the microbiome. There is two key things. This is all the gut microbiota manipulation we can do. And maybe we have some good result when we use some microbiotherapy for patients in a treatment failure, but so far this is only in patients that fail steroids and ruxolitinib, but maybe one day it will be moved earlier in the treatment. It will be given at the same time in the first line treatment. The other thing, this is regarding nutrition. So now I am looking at Zina because we have a lot of discussion on this topic during the EBMT. So far with patients with GI acute graft-versus-host disease, we stop every diet, and it seems that it is detrimental also for the microbiome, and more teams now are trying just not to put to stop all diets and just allow patients to eat, and it makes things more difficult to evaluate graft-versus-host disease severity, but at the end it may be good for the microbiome and for the patient overall outcomes.
Thank you very much, Florent, for these details. Anything to add, Professor Nagler?
We never gave antibacterial prophylaxis for many reasons, including lately microbiome. We actually do like it was said, we gave anti-BCP, we change antifungal, and we give anti-herpes zoster, so acyclovir, but never gave preventive bacterial, but very much alert, and all of us lost some patient with grade 4 acute GvHD within 24 hours. And every time that it happened to us, it's rare, but happened, then there is a huge discussion and so on. It can happen in the middle of the night, it's suddenly a sepsis and the patient is not alive next morning, but we still don't give prophylactic antibiotics.
Thank you, Arnon. What about now, let's move topics to antifungal prophylaxis, and I'll come back to the viruses. Are there any recommendations there, any guidelines? Is, for instance, the use of posaconazole common practice everywhere? Zina, you would like to jump in?
Yes, sure. So yeah, in steroids, when we give steroids more than 1 milligram per kilo, when it comes to fungal prophylaxis in generally, in the first 30 days in aplasia, we also do it in the first 30 days after transplant. Afterwards, we change to fluconazole.
This is the same practice everywhere. I can see Robert agreeing.
Same practice in Germany. Maybe if a patient has, let's say, liver problems, we use a less liver toxic agent, like ambisome, for example. But other than that, we follow the same guidelines.
Ibn?
We use fluconazole standardly, just fluke 200 peri-transplant through their entire nadir and so forth. And if they and stop it fairly quickly after transplant once they engraft and leave the hospital, though obviously it's all about the drug-drug interactions and stuff. And then when, as I said, when they get admitted for gut GvH, and they these days rarely, and they need the high-dose steroids, they go on IV mycophenolate while they're in the hospital. What they leave on, if they recover and respond, and it somewhat depends on their course. But if they haven't shown any signs of a serious fungal infection or mold infection, we go back to fluconazole.
Thank you very much, Ibn. And by the way, I'm not able to see on my screen everybody, especially if your camera is switched off. So please don't hesitate to jump in if you would like to add something. How is it in Belgium? I can see Frederic Baron, who has just joined.
Hello, everybody. We do the same. We change fluconazole to posaconazole when we give high-dose steroids.
Wonderful. Amin, something special in Texas?
Yeah. We have pretty high rates of invasive molds, probably related to the climate in Texas and in Houston in particular. And we have high rates of mortality related to fungal infection. So yes, we use in patients on steroids and routinely in prophylaxis for the majority of our patients. We use mold active azole, so Posa or voriconazole or Cresemba. During the course of early conditioning, we typically use caspofungin and then switch after, like post-transplant cyclophosphamide, back to an azole.
I mean, may I say something? I mean, like,
sure.
Amin brings up a good point. I mean, the question is, when we discuss this and when, people get together and write these guideline things, I mean, should it be one size fits all? I'm not sure it should be. I think it depends on your background, sort of rate of infections and so forth, right? If you look at different centers from different geographical regions, whether it's the climate or the diet or the microbiome or something else, the background rate of these types of infections are just totally different. And that probably, and hence there's a different risk. And that probably should dictate the prophylaxis. I'm not sure it should be one size fits all just because some complication happens.
No, you're absolutely right. And I think this comment is well taken, Ibn, because obviously, especially for fungal infections, we know that there is a gradient between north and south or south and north. And this has been described. And obviously, you won't handle a patient in a tropical zone similar to some city closer to the Nordic pole and so on. And actually, this is also true, although we won't have time to address this for some specific, I would say, local situation. Recently I got questions about, dengue management and prophylaxis. There are zones where you may have an epidemic situation of tuberculosis suddenly. And so, Okay. Last part is about the antiviral prophylaxis, which, I mean, you alluded to it, most of you, but just maybe to highlight the monitoring of viruses. Which viruses actually, and how frequently would you do it, and when would you decide to treat? And for instance, the most popular ones, I guess we can address many viruses, are CMV and EBV, for instance. CMV, what is, I would say, the current standard for you, Frederic?
We do prophylaxis with Previmis, and then we do a PCR once a week for the first.
So this is letermovir, by the way,
Yes,
and is according to its label. Yes.
Sorry. And then we do a PCR once a week, up to day 100, and then every 2 weeks, up to 6 months.
Okay. And is letermovir common practice everywhere, or there are barriers for this? And for how long actually would you do it? For 3 months or for 6 months based on the most recent study?
Yeah, in Belgium, we are stuck to use it on 3 months because it's not reimbursed beyond day 100. But it's too bad because we saw some.
And Frederic, if I can ask a question, so if you have an acute graft-versus disease receiving steroids, you will stop the letermovir at 3 months, even if it's still receiving full dose of steroids.
We have to for the reimbursement, but sometimes we ask to the insurance to have the authorization to prolong it, but we always have the response after a few months. So
so you will do the same as us, as long as they receive high doses of steroids, you will keep the letermovir, but you can't do it for reimbursement issue.
Yeah, exactly. Yeah.
Same with us. I mean, it's the use of letermovir beyond 3 months for a patient with GvHD still on therapy is fully dependent on the payer. We'd like to keep them on, but it just depends on if they will get reimbursed.
Okay, but I believe that outside the issue of reimbursement, everybody would agree that letermovir is dramatically, I would say, allowed to decrease the incidence and the problems we usually face with CMV, and it has become like a sort of a very rare cause of morbidity. What about EBV actually? Any thoughts on this? Amin, you opened your mic, I see.
No, not purposefully, but I'm sure I can comment on EBV. We do screen for EBV in particular cases. Some cases, especially those who have received prior CAMPATH or ATG, for instance, or aplastic patients. Obviously, we have very specific screening guidelines for and close monitoring for EBV. We do screen for EBV in other contexts, in cohorts and even our haploidentical populations, although I don't believe it, at least in the haplos, we have data to support the need to do so, but that is our practice. We don't routinely screen otherwise in, for instance, a matched SIB or a fully matched MUD. Unless there's reason, again, based on prior exposures, if you have a T-cell leukemia patient that received CAMPATH or such therapies in the past, that may change, or a PLL patient, for instance.
Zina?
Well, I'm so glad you raised this question because for the last several years, we've been discussing how do we evaluate EBV because we have found really a significant difference when evaluating EBV from the full blood and from the plasma. And there's some data, it was a publication in Blood for some years ago, it was in pediatric population where they saw that actually EBV done in plasma correlates better to the PTLD development, and that's the real EBV. So the EBV in plasma, in the cells, it correlates to the real EBV that we worry of. So the full blood EBV is usually higher, and what we do now regularly to evaluate when we have some positive EBV in full blood, we do it in plasma as well. And if plasma is negative, we just do not act. We just do not act on the full blood.
I think we use plasma routinely at our center, but the question is at what value do you preemptively use rituximab? I don't believe there's strong data one way or the other. Often, we follow closely when we start to see it, but I believe around 4,000, 5,000 copies, and it depends. You would probably have a lower threshold in like a cord patient, I would suspect. Zina, do you have particular guidance you use at your center?
So in the full blood, and I remember, I don't know, Mohamad, how you changed the practice in your center, and Florent, because I know that you've done also in the whole blood, and it was 5,000 in the whole blood, and that's what we followed for some time, and then we thought it was like a too strong, or too low limits, and then after evaluating in plasma, then we do not even have like the specific threshold, but if we see a positivity in plasma and then an increase in plasma, so we do it regularly, then once a week, then we would act. But to be honest, I do not remember last time that we don't use it so much after, and we do not see PTLD much as well after we have started this evaluation in plasma. So I don't know what is your experience, but I know that we have been much more strict earlier. We would give rituximab earlier.
So let me move this question one step forward, irrespective of the technique and the threshold, which I believe are going to be different from one place to another. Once you have declared, I would say, EBV positivity, so reactivation, and I'm not talking about PTLD, you would decide to treat with rituximab. So is it about just a single shot of rituximab? Is it about until it becomes negative again, the EBV viral load? Or is it, you just give 4 doses of rituximab for 4 weeks and that's it? What is the current practice? And I've seen in the literature all kind of scenarios, actually. Ibn, what is your practice? Very pragmatic, your SOP for fact.
If we've decided to treat EBV reactivation, it is 4 weekly doses of rituximab, and then we certainly monitor the viral load and go from there. If it's downtrending by that point, I guess it depends on what the value would be, but we would stop at that point and observe before giving more. Hopefully at the same time you're able to taper immunosuppression, but that is obviously dependent on the patient. I will make a comment and say I would have more firm recommendations, but we just don't see it anymore, right? So with the move towards PT-Cy based regimens without polyclonal anti-T cell antibodies, which we don't do usually for our mismatched donors, we've all seen the data where there's very little EBV reactivation after PT-Cy, right, compared to T cell antibodies, and so we just don't see it. I mean, we will screen for it in a GvHD patient generally when their LDH starts to climb, right? That's the first clinical indicator. But that LDH rise for these patients these days is usually because of either a little bit of thrombotic microangiopathy or because we've added ruxolitinib, which makes the LDH go up. And so we just don't see EBV. I can't remember the last time we had to treat for EBV.
Okay, so I do understand this, but again, my question where I would like to get the different opinions, because some investigators claimed or hypothesize that by giving actual rituximab and being quite liberal, you will also help to decrease the incidence of chronic GvHD. Robert, what are your thoughts on this?
So when it comes to EBV reactivation, we monitor it once a week in the first 2 months, and then we react, like my colleagues have already said, with rituximab. We also monitor actually the B cell counts, and in patients that have almost 0 B cell counts, we do not give rituximab. Normally, we give a dose of 100 milligram rituximab, and then measure the EBV counts again. I must say that EBV reactivation or even EBV-induced lymphoma is extremely rare meanwhile. We see some copy number alterations sometimes, but it's rare that we have to treat. I would say twice or 3 times a year, I would say we have to treat EBV in our institution. And in patients that get immunosuppression for chronic GvHD, we still monitor it, depending on the severity of the immunosuppression, I would say. A patient with severe chronic GvHD who is on 1 milligram per kilogram body weight, corticosteroids, we monitor it, I would say every other week. And then in this patient with very low immunosuppression, we monitor it once a month.
Wonderful. Thank you very much, Robert. I think we can spend hours and hours discussing this. What I can hear from all of you is that there are some good news when it comes to CMV, when it comes to EBV reactivation and PTLD, where we see the incidence and likely the severity of the morbidity of these complications are decreasing. We didn't speak because we can't handle everything in the same discussion. For instance, we didn't speak about BK virus because obviously with post-Cy, which is helpful for maybe some other complications, maybe favoring BK virus reactivation and hemorrhagic cystitis. Good news in terms of bacterial prophylaxis. It looks like bacterial infections remain a matter of concern, and we are, I would say, always in a split between the issue on how to protect the microbiota and, on the other hand, how to handle this. So this was a lovely discussion. Thank you all.